discuss the issues. John.
Thanks very much, Dr. Goldenberg. Now I'm going to start with a story this morning. It's a beautiful morning, and I'd like you to imagine a beautiful day in ancient Greece. Zeus, the father of the gods, is holding a banquet, and it's to celebrate the marriage of two gods, Peleus and Thetis. Now, Eris, the goddess of discord, isn't invited, because obviously she'd spoil the party. But she finds out about the party, and angered by the fact that she's been left out, she comes to the occasion and brings with her a golden apple. And the apple's inscribed with the words Calliste, which is Greek for the fairest one. Now, instantly, when she introduced the apple, three goddesses wanted to claim it. Hera, wife of Zeus and goddess of marriage and women. Athena, daughter of Zeus and goddess of wisdom and war. And lastly, Aphrodite, who's another daughter of Zeus's and was goddess of love and beauty. Zeus understandably wanted no part of judging this family affair, so he chose a mere mortal, Paris, a Trojan, to judge the competition. And this painting by Rubens hangs in the National Gallery in London, and it depicts the scene from the Judgment of Paris. Paris is on the right of the picture, and Hermes with the wings has brought down the goddesses for him to judge. As is right at this kind of occasion, the goddesses present themselves to him naked to prove that they're the fairest, and, as is customary in this occasion, the goddesses offer bribes. So, Hera offered to make him the king of all of Europe and Asia. Athena offered him wisdom and skill at war. And Aphrodite offered him the most beautiful woman in the world, and that was Helen of Sparta. Paris, being a man, accepted Aphrodite's gift, the most beautiful woman in the world, and awarded the apple to her. At the time, Helena was the wife of one of the Greeks, and this is the mythological basis of the Trojan War. And this is a classic example of how a small matter can lead to a much bigger dispute. And I'm going to leave the story there to move on to PSA, because recently the debate was reigniting and the temperature was hot. The official statements are on the screen here from the relevant societies, but some of you may remember when this was presented, the judgment that PSA screening should not be either enacted for men with, in terms of screening for prostate cancer, the position was polarised. And perhaps social media in this current era best encompasses the heat of the situation, where Matt Cooperbird, an eminent urologist, said, "I hope Tim Wilt knows in his heart of hearts that thousands of painful, slow, preventable deaths will indisputably rest on his head." And moving on to something more objective. So, WHO screening criteria. This slide lists the criteria for good screening tests and for screening suitable diseases. I'm not going to keep referring back to it, as I'm sure you're all familiar with it, but try and keep these points in mind as we move through the presentation. Prostate cancer is common, and without a doubt it's a public health issue for men. This slide illustrates recent statistics, drawing to attention Canada at the top of the table. The current incidence is estimated to be 26,500. And we have some insight into the natural history of what happened to early prostate cancer pre-PSA screening from this study by Johnson and al., and also the work by Albertson. And if we think about it and we extrapolate the data, it's difficult to bring it into current practice, but it did demonstrate two key facts. Essentially that not all prostate cancers need to be treated, and also that to determine trends in prostate cancer interventions, it takes a significant period of time. So in this study, it was 21 years of follow-up. PSA itself, the blood test, was introduced into a role as potential screening intervention in the 1990s. A number of papers were published and a lot of interest was shown as to whether or not it was better than digital rectal examination alone and current methods. But as time progressed, the limitations of the PSA were identified, which is primarily that it's organ specific, not cancer specific. And secondly, what's a normal PSA? And the prostate cancer prevention trial illustrated this nicely. The bottom table illustrates their finding, and that's to say that if there are low PSA values and those men are investigated, surprisingly or relatively high levels of prostate cancer may be found. Now, we all know that not all of these cancers need treating, and this raised probably for the first time, the concept of overdiagnosis. But despite its limitations, I think everybody has to acknowledge that since the introduction of PSA, there must have been some kind of effect. And these graphs illustrate the incidence and mortality rates in the US and the UK. On the left is the US, on the right is the UK, and we can see on the top the incidence characteristics. And essentially, prostate cancer incidence has increased. In the US, it's plateaued a bit, and in the UK, it continues to rise. In the US with regards to mortality and the UK with regards to mortality, from 1990s onwards, there's been a steady decline in prostate cancer mortality. It's more difficult to see in the right-hand graph, but if I just reassure you that the 1990s start approximately here.
But in the UK, we don't see that surge, so there was no initiation of widespread screening in 1992.
No, that's correct, and I will mention this later in terms of we are certainly more conservative in our approaches to.
Can you go back one, John?
Yeah, sure.
So what's the absolute difference in mortality between the US and the UK? Because I can't read the.
Okay, got you. So in terms of the y-axis for the mortality, the US demonstrates the statistics currently in terms of Caucasians, Afro-Caribbeans, African Americans, and other. But in terms of absolute numbers, y-axis, top line is 100, and it's 20s per each line. With the UK, it's 5s, and then 8s, and then 16s. So where the numbers are the indications are 8s and 16.
But is it true that the UK's mortality rate is higher than the US's?
I think that's accurate, potentially. Yeah, it's not saying. Yeah, it's true. I'm going to move on. I think what's probably important at this time is just to review the current evidence with regard to PSA screening, and this is a motive and subject that's debated. And in terms of trials of significant quality to demonstrate a use, these are the studies that I'm going to discuss today. So we'll start with the Tyrrell study. This was a real-life natural experiment, and it compared prostate cancer outcomes in men from the Tyrrell region essentially versus the rest of Austria. What they did was they exposed men in the Tyrrell region, approximately 65,000 men who were between the ages of 45 and 75, to a mass screening campaign. So doctors, nurses, buses, radio adverts, with regard to PSA testing. They then observed what happened in the population. Approximately 32.3% of men responded to the first invitation, and by 5 years, approximately 2/3 of men had had a PSA blood test. And all the men who were diagnosed with prostate cancer, importantly, were treated aggressively. And this year, updated results have been published. And this is a summary slide in terms of a graph to show what happened to the mortality rate. So these are age-standardized mortality rate per 100,000 on the y-axis and year on the x-axis. And the vertical line indicates when the study last published its data, which was approximately 2004. The black line illustrates the Tyrrell population, and the dotted line indicates the population from outside of the Tyrrell region. And what you can see is that both lines demonstrate, after approximately 1996, a decrease in the mortality rates, but there seems to be divergence and clear water developing between the lines as time goes on. Now, the purpose of them publishing this paper was that it reached statistical significance at approximately 16 years post the study being started. This study is limited by the fact that it's a historical cohort. There was no validation of potential reasons for cause of death, and there was aggressive treatment and probably downsizing or downstaging of tumours, but the trend is important. The Quebec study, which was allegedly the first PSA screening trial that was randomised, attempted to randomise 46,000 men between PSA screening and no screening. And the trial highlighted the difficulties of just attempting to do this. So just to show, on the left-hand side, it shows those who are not invited to screening, and that was approximately 15,000 men. But of them, 982 men were actually screened. A reason for this isn't given. In terms of the invited men to screening, only 7,155 men presented. Now, screening involved an annual PSA and DRE, and for the first 1,000 patients, they were offered a transrectal ultrasound scan. And in terms of the reported results, they reported a death rate reduction from screening of 62% in the screened group. But what they'd actually done was taken those who'd been screened, going back to the slide, from each side of from not invited and invited, and combined the data. This study was understandably heavily criticised because it was contamination, and in actual fact, if you'd left both groups where they were on an intention to screen basis, there was no difference in mortality. So let's move on to some level 1 evidence. This slide illustrates the data from the prostate component of the PLCA study. This was a prospective randomised controlled trial looking into the benefit of screening, with primary outcome measures being prostate cancer-specific mortality, incidence, staging and survival. 76,000 men approximately were classified into the two groups when they presented to 10 US centres. Annual PSA and annual DRE were the interventions for the screening group, and a PSA of greater than 4 was the trigger for further investigation. The bottom of the slide indicates the number of cancers picked up and the deaths. Bottom line, there was a little difference found between the groups in terms of tumour stages, and the study concluded that there was no significant difference in the mortality between screened and non-screened populations. I think the first question we have to ask about this study is, well, why was it published when it was in 2009? And the reported reason for publication was essentially because an independent group that was screening the results 6 monthly felt that that was the right time to report that no difference had been made between the two groups, and therefore potentially men were being exposed to making screening decisions based on inadequate information. There were other limitations too. I mean, there was contamination of the control group. 9.8% of people were screened prior to entry, and 40% had already had a PSA test by their entry into the trial. This had risen to 50% by 5 years, and this is likely to demonstrate why there's no effect for intervention. And we've got to ask whether this study can actually ever answer the question. Updated results have recently been published. Cumulative incidence rates have shown significant increase in the number of new cancers diagnosed. However, there's no difference between mortality rates, and that was this year. In the European screening study that was actually published at the same time, this slide illustrates the characteristics of that group. 162,000 men were separated into screening and no screening. 7 centres participated, and in terms of the PSA screening intervals, in the majority it was 4 yearly. In one centre it was 2 yearly. And the triggers used were 3 and 4 in terms of PSA. You can see from looking at the numbers at the bottom of the flow diagram that there were more cancers diagnosed in the screening arm and less deaths with respect to the other side. But statistically, was this important? The main ERSPC findings were that essentially there was a reduction, and it was relative in terms of the risk of death from prostate cancer of 20% in the screened group, but that came at a cost. 1,400 men needed to be screened and 48 cancers treated to prevent 1 death. Now, the limitations levelled at the study is that it's a collection of different trials in different countries with different eligibility criteria and randomisation and screening strategies. And also, there's the effort that different treatments in different centres as an effect may be difficult to ascertain. They too have updated their results this year, and the relative reduction in the risk of death when adjusted for compliance for screening was 29%, but stayed consistent at 21% for the entire screening group. In terms of the numbers needed to prevent one death, the terminology had changed, but the numbers had decreased. So 1,055 men would need to be invited to screening. 37 cancers actually need to be detected to prevent one death. So where now? Well, 2012 has really been the year that's been fertile for updates and subgroup analysis. So the European studies looked at a breakdown of 4 centres' data, looking for what's the risk of developing metastatic disease. In terms of the population, 76,000 men, split into 2 almost equal groups, and more cases of metastatic cancer in the non-screened group. And this seems to be most significant at diagnosis. On analysis, it was attributed that the 30% relative risk reduction in the diagnosis of metastatic cancer could be attributed to screening, but again, coming at a cost. Quality of life studies have been published saying that there seems to be a net benefit. And then we've also got Gothenburg as well. So this was a single group of the European study that looked at 20,000 men randomised to PSA screening at 2-yearly intervals. And they demonstrated a dramatic reduction in the mortality rate compared to the control group. I think this illustrates 2 things: what potentially could be an outcome, but also the effect of one centre on a whole lot of data as well. In mitigation for this group, not all of the men who were diagnosed with cancer were necessarily treated actively. So a third of the men managed to stay on active surveillance. Which brings us to this slide, which is busy but essentially summarises the review of the evidence by the US Preventative Task Force. Essentially, do not use PSA screening for prostate cancer. What's the current medical position? Well, maybe we should have a straw poll. I think if we look at a 55-year-old man presenting to a family physician and he's asking you whether or not to pursue screening for prostate cancer with a yearly DRE and PSA, you're the audience, but you've heard some of the evidence. How many people here would offer him counselling regarding screening, followed by screening afterwards? Put your hands up if you'd go with screening.
You can't answer that with just that information. You need more.
No, that is true. But just on...
And, yearly, every 2 years, risk factors. And so
Okay. For a single PSA, and he's coming to you now and asking you whether or not he should get screened, who would offer screening? Commit. Okay. So that's probably about 60% in the room giving a position for screening.
It's a very biased room.
It's an extremely biased room, but the next...
Towards the prostate side.
That's true, but the next slide will actually illustrate the point, really, which is this question was asked in the New England Journal of Medicine to people reading their issue, having given a debate and the article's been presented and the evidence with screening versus non-screening. And 54% of people who responded, and there were 1,000 respondents, said that they would counsel the man and then offer him screening. But you can see it's the debate or the report's answers are polarised by where they actually are from, and also, you know, different. So from Australia, for example, very few of the guys who responded actually advocated for PSA testing, whereas conversely in North America, people were more proactive. But the general state is confusion. And what's the reality? Well, Obama was elected as president last night, but if we look back to a year ago, he was getting his PSA tested. And is this just the educated man? Now, this slide is a busy slide, but I just want to take out a few excerpts because it's very difficult for medical people to put themselves into a patient's perspective, and I've tried very much to do that for this presentation. And this gentleman, this is a quote from an online blog, and I realise that this is again a biased population, but actually encompasses a patient's perspective quite well. So I know other men like me who've had treatment and who, given their age, tumour volume and Gleason score, will almost certainly live longer because of that treatment. For men like us, the side effects are worth the treatment effect. I think that part of the quote illustrates the patient's perspective that statistics on their own are very difficult to interpret and to influence their position. They're more likely to be influenced by people they've seen and people that they know. The next position is this, which is your position on this issue, which is based entirely on the statistics and ignores individual differences, would almost certainly have doomed me to die of prostate cancer. How is that ethical and responsible? The PSA test saved my life. How is that not useful? Just ignoring the information because some people will make the wrong choice is impossible. Again, perhaps an eye-opener for me. I think the patient's perspective generally, though, is that they see medical confusion, they want guidance. They are capable of making informed decisions, but generally are poorly informed, and that's what randomised control studies have shown previously. There's also strong data to suggest that information given to patients doesn't necessarily correlate with an increased PSA uptake. So there may be a role here for the Informed Medical Decisions Foundation. There's also a wider philosophical issue here, which is essentially we're disconnected with death. I'll use BC as an example. The average population that come through into the clinic here are very unrepresentative of what happens in the UK. I've seen 80-year-old mountain climbers here, and my approach and their approach to life has to be tailored to the individual and certainly changed. And that has impact that RCTs don't necessarily always address. The other problem with RCTs is evolution, in that prostate cancer treatments will change, paradigms will change, and outcomes will change as the centralisation of cases as well. There's no doubt that better investigation suites will come and we'll get better tests in the future, but maybe we're labouring the wrong question. And this is just postulating, but maybe the right question is not whether or not to do the PSA screening test, but actually how do we get the right information to the right men in the most appropriate way for them to make a fully informed decision. So, to summarise the evidence today, PLCO screening doesn't affect mortality. European study, it does affect mortality, but it comes at a cost. We know that we've got good treatments. This is Bill Atkinson's most recent data that can exert an effect on prostate cancer outcome and mortality. And the aim of showing this slide isn't to go into the depths of the paper, it's just to illustrate a point. We also know that we're over-treating disease, so we know that observation versus radical prostatectomy is a viable option for low-risk prostate cancers and some intermediate-risk prostate cancers, and our difficulty is picking between them. Treatment paradigms and acceptance levels of active surveillance have changed, and we would widely advocate that active surveillance, certainly in Canada and the UK, has been widely adopted for patients with low-risk prostate cancer. The BCCA position on PSA screening is as follows: that they recommend that asymptomatic men with 50 years of age or older with an estimated life expectancy of more than 10 years, who are well informed about the risks of overdiagnosis and overtreatment, consider PSA testing for the early diagnosis of prostate cancer. It doesn't support unselected population-wide screening. And in this talk, I've not addressed the economic impact of this, and there are always going to be countless thousands of studies that we could always talk about or angles that we could go down. But to give a flavour of where certain urological societies are sitting at the moment, the Canadian Society advocates and endorses screening. The most recent update, 2011, certain authors are in the room. American Urological Society advocates screening. We were all aware of that and at an earlier age. Officially, the Urological Society of Australia and New Zealand endorses screening, and in Europe, we're sitting on the fence. We say it's okay in the informed man, but in general, we don't advocate it.
John, can you just hold off for one
yeah,
second?
sorry.
So it's interesting that in Europe, where you've got the strongest evidence, you're sitting on the fence.
Yeah.
But isn't it really that they're all saying kind of the same thing? That nobody, even the CUA, I don't think represents population-wide screening. They're recommending letting the man become informed and make his own choice.
I think that's very true. But it's a question of perception. So if you are a family practitioner or accessing the CUA site, then the conclusion of their assessment is that PSA can be offered and should be offered to men over the age of 50. It's in an informed way, but yeah.
The BCCA recommendations, right? I mean, it's just more explicit in the BCCA that we're not recommending population-based mammography like.
I think that's true, but I think the counterbalance to that is that there are certain sides of that education debate that people sit on, and I guess if you imagine it as a seesaw, the Europeans sit more on the side that say, well, actually, let's hold it back a bit and not do the PSA, and would be more likely to bring that up. And interpreted by the family doctor or people not necessarily armed with all the information, it makes it harder for them to judge what to do. And I guess what I'm trying to do in this talk is polarise one way or another opinions for discussion. And I think that's the point. And that, really, in summary, is the apple of discord. And I think it now is a good opportunity to talk about the various aspects in slightly more detail.
Good. Thanks,
Thank you.
John. Very well.
Yes.